All right. I want to make sure that this is actually going to show you my screen, and that will be good. Hopefully, once it clicks forward. All right. Well, good afternoon to those of you in Ohio. Thank you for joining me for part two of this lecture on the psychopharmacological management of individuals with intellectual disabilities. I do want to start out just by, taking another big thank you to everybody who's taken their time out of their schedules to watch me do this. And it's just allowing me to be part of this project, which I think is really cool. And then obviously a big thank you to Doctors Gentili and Cowan for allowing me to participate and having that confidence in me to do this. So thank you. And again, to the Ohio Department of Mental Health and Addiction Services and the Department of Developmental Disabilities for having this put together for everyone. So thank you so much, and we will get started. And hopefully my screen changes. Did not. Okay, you guys can see everything. Oh, there we go. Okay. Looks like it's working now. Sorry about that. So I still, even from last time, I still don't have any financial disclosures or affiliations. So there we go. For those of you who don't remember me, well, my name is Dr. David Dixon. I am an ABPN board certified psychiatrist. I did do my original training in Arizona as far as my bachelor's degree was at Arizona State University. Go Sun Devils. I went to medical school in Arizona at AT Still University, School of Osteopathic Medicine in Arizona. And I went to residency, very fortunately for me, out there at, question. I went to residency at Wright State University in Dayton, Ohio. The question was, I missed part one, will this be offered again anytime soon? I believe there's an online video already there, so you might be able to figure that one out later, but it's there somewhere. So I'll go back to my, yep, you're welcome. For my first career as a psychiatrist, I worked in the United States Air Force. I was the medical director at the inpatient psychiatric unit out there in San Antonio, Brooke Army Medical Center, where I also functioned as a psychiatric clerkship site director for the Uniformed Services University. I am currently in the reserves with the Air Force out of Fort Worth, Texas, so I get to do a little bit of traveling. I presently work for a company called Second Chance Treatment, where I do a lot of addiction psychiatry, telehealth. And I'll be moving to a company called Talkiatry in December, where I'll be doing telepsychiatry, general psychiatry, and that will be in Ohio, actually. Also, I'll be seeing patients out of Arizona and I think New York as well. So look for me there in those places. And then I still function as a clinical assistant professor of psychiatry, teaching residents at a Wright State University, which I love. And I do a little bit of adjunct teaching out of AT Still Soma. So, alrighty. So we're looking at who here is sitting with us. Well, I mean, I'm assuming pretty much anybody who's involved with anybody who has intellectual disabilities. So possibly people with intellectual disabilities themselves, caregivers. So when I talk about caregivers, I think about the parents, the guardians, family members, really, but anybody who's part of that inner circle. And then I'll talk about providers a lot, social workers, nurses, case managers. You guys can read as well as I can read. So all this group, potentially legal professionals, so can definitely be involved in these cases, and I hope they get something from these lectures. And then anybody who really wants to learn about this topic. Now, the part one is really designed a lot for the people that are maybe not in the physicians group as much, but this one is catered towards the providers more, but really also the caregivers. I want the caregivers to have some familiarity with medications for this population. And I really want you to feel empowered when you are going into these appointments and feeling like, hey, I can ask questions. I have some knowledge about this stuff. Okay, so that's really what we're trying to do. So the first our first objective is covered in our first lecture. This is part 2. So we're really going to look at the kind of the general guiding principles with medications, and then we'll look at a lot of like the recommended practices and monitoring. Okay, so some of the things that we should be doing when we're prescribing these medications, just how do we do that? Maybe we're some tidbits, some pearls, and just some things like this is what I should be seeing, whether I have a patient who's using these medications or I have a family member or just somebody I love or somebody I'm taking care of. Am I seeing that this stuff is being done? Okay, so if you have any questions, please, you can ask in chat like you did. I'll try not to be so awkward with it. I'm trying to get used to the left and right thing I'm doing right now with multiple screens. But if it's a question that I'm going to answer, I'll probably just say that and answer it in the coming slides. If it's something that requires maybe a lengthier discussion, I'll try to get to it. We have a Q&A at the very end, but if it seems like it's very topical and something that I can add that really adds to the lecture, I'm gonna go ahead and throw that in. So feel free to ask the questions. I won't try to ignore you, though I might get distracted, so I apologize. Just as a refresher, we're gonna just kind of go over some of the things that so that you remember from the last lecture, or maybe you missed the first one, right? So psychopharmacology. So what is that? What does that big fancy word mean? Well, realistically, it just talks about the medications that we use to treat the symptoms that are related to the way that our minds function. So not really how we cure the psychiatric disorders, but just the medications that kind of help us treat those underlying symptoms, okay? And for those of you who are considerably younger than myself and don't know what TLDR, or older than myself, or even honestly my age, but don't know what TLDR means too long, didn't read. But basically these medications and the science to which we use to figure out which medications affect how our mind works. All right, so one of the big things I think is probably the most useful thing to just kind of as a baseline for medication is what are SIGs? What does this even mean? So if you remember, so SIG is it's the short for the Latin signature, which means let it be labeled. Okay, and so here's a couple of examples. I'll just kind of break them down. What we should have in a SIG, and this is important whether you're prescribing or whether you're getting this medication, and I do believe, especially with the ID population, it's very important that SIGs be very specific. And so what we should have is we should have, with aripiprazole, we should have the name of the medication, whether it be generic or brand name versus some molecular name. So this is the generic name for a medication. There's a different brand name for it and a completely different molecular name, which I have no idea what it is. It's the actual like molecules that make it up. It should then, which is aripiprazole. So then we have the number 5 in the mg's milligrams. So that's going to give us the dose that we're expecting. Tab tells us what the formulation is. So it might say tab, it might say capsule, all sorts of liquids, solution. Next it says PO, which means per Oz, and that means by mouth. And this is the route of administration that should come next, whether that's SL, SQ, IM, IV, transdermal, whatever it is that you should know, how am I giving this medication? Next comes the frequency, so that's QHS. Q, if you see that, means every. HS means before bedtime, or means bedtime. QAM would mean every morning. When you see things like BID, TID, QID, those refer to how often you would take it. So BID would be twice a day, TID 3 times a day, and QID, if anybody can remember, that's actually 4 times a day. That's a confusing one because Q also means every, right? But then there's QOW, which is every other week, or QOD, which is every other day. One that you won't frequently see is PRN, at least with this population, you shouldn't be. A lot of agencies won't allow for that, and that's fine. We aren't always going to be doing PRN, but that means as needed. So you'd say you take this at bed as needed. Then it should have the indication. This is really important that we have an indication. Okay, so something that I really like to harp on is that we say, why am I giving you the medication? And that's something that if you're not seeing that on the SIG in the bottle, we really want to know, okay? And it's important, I always tell my residents, hey, you need to know why you're giving medication if you're going to give it. I think that's kind of the first step in proper prescribing. So these are 3 examples of SIG. So fluoxetine, 20 milligrams, capsule, by mouth, in the morning for depression, trazodone, 50 milligram tablet by mouth before bedtime, as needed for sleep. So it isn't one that you necessarily take every day. Okay. All right, let's move on. So let's talk about some of the more general guiding principles just on how we might use medications for this population. I like to think of this. So whenever you're thinking about prescribing medications for anybody really, we should really follow most of these rules that we're going to talk about. But I think they also become particularly important when we're dealing with the vulnerable populations. All right, we always want to have a plan that we can clearly communicate to the patient, the caregivers, other providers, and we want to write those down. So even we're communicating to ourselves as we're prescribing those medications. Okay, so this hokey acronym that kind of just happened as I was writing this up it's there to help you sort of tailor those treatment plans for patients. Okay, and so you can do that by starting at the seams. Isn't that awesome? See, everyone's laughing and loving my dad joke there. But to have that clear plan in place, we have the seams. So we're going to talk about the symptoms and behaviors, the expected effects, alternatives, most with the least rule, which is really good to know, and then simplify the regimens. Ooh, there we go. So starting with the S, the symptoms and behaviors, we want to make sure that we're establishing and documenting what the symptoms and behaviors are that we plan to treat. So before we start any treatment. If possible, we want to try to quantify those behaviors with like 0 to 10 scales, just some way that we can have an idea, okay, if I was going to see you a month from now, how might I compare? Okay, just want to figure out some way to like identify what the intensity or some sort of significance of that behavior is at baseline. And so sometimes we'll say, like, if you had to rate your depression on a scale of 0 to 10, where would you put it today, with 0 being nothing and 10 being the worst? And you could do that with agitation. You could do that with really anything if you want to. It's your scale. It's incredibly subjective, but sometimes you find that, you know, using some level of objectivity with these subjective scales can be useful, because maybe the next time I talk to you, maybe the first time you said I'm at a 7. Well, a month later I've been on medication or I've been doing some sort of treatment and now I'm at a 3. Okay, well that shows some level of improvement that otherwise I may not have known about, but at the very least now I'm seeing that in you, and that's coming from the patient or from the caregivers or really anybody else. But it's a really good idea for us to also be able to identify any adverse effects that might occur when we're using medications. So just having that, hey, this is what I'm seeing. Oh, look, this is something new that we didn't talk about last time. Was that there? Maybe it was, maybe it wasn't. And so we can sort of identify that. And it's always a good idea, if it's possible, to use a rating scale. And I like, there's the PHQ-9, some, you know, the free ones. There's the PHQ-9, the GAD-7, PCL-5. There's the Vanderbilt Y-Box. All sorts of skills that we can use out there. I think the key is just to be consistent, at least with the patient that you're using it with. I don't know that I would say that I would base everything off of rating scales. I wouldn't say that, oh, this is what you have to use, this is the only way. I would really just say, let's use this as a tool in our kit to kind of help us understand, are we making progress, are we not? But also be able to read between the lines. And sometimes people are just a bit more distressed when they come in. And so maybe their scale wouldn't actually be that high, but today they had they were almost had a car accident right outside your office and they were doing fine up until then, or something like that. But a lot of times we're using scales like these that require somebody to fill something out. We do have to make sure that there's a higher level of communication with our patients, but still something that we can do and we shouldn't turn our noses up at. And really what that comes down to is that we should always be really interested in what our patients feel is the most important thing. And I would say let's also add into that the caregivers, because I want to know what their priorities are. We should really try to establish what their priorities are going to be. What do they want to focus on first as we're going through treatment? So for instance, I might want to really focus on anxiety, but maybe sleep's the bigger priority for the patient and the caregiver. And honestly, anybody who's ever had their eyelid peeled physically open at 4 a.m. By a 4-year-old child or somebody else in the house who just wants you awake can appreciate why it might be important that the higher priority might be on helping them get through the night. Next, the expectations. So we should be looking to establish with our patients and the entire treatment team that what the expectations are going to be for our medications. So just think about that. Nothing can be as frustrating to this patient or caregiver when you go through this effort of seeing a doctor, getting a diagnosis, coming up with a medication, going out, getting a prescription, going and filling it, paying for it, right? If you can, right? Going through the prior authorizations, all the insurance stuff, getting home, and then maybe even having a hard time getting somebody to take a medication, getting some sort of conflict over it, and then all of a sudden, and then you're not seeing improvement, right? You're not seeing something immediately. Or even worse, you have some sort of side effect that they had no idea was going to happen. And like, how frustrating would that be to have gone through all of that with no result? And so we can avoid a lot of that frustration just by taking that time to discuss these things, to let them know, hey, this is how long I expect this thing is going to take to work. This is when I expect side effects to occur, which in a lot of medications, you're usually going to see a lot sooner, usually within the first few weeks, versus like, when am I going to see the benefits, which is, might be a few weeks out, might take 2, 4, 6 weeks to see maximum benefit with medications. And then really what we're expecting. So what is it that I'm actually, what are we expecting to see? Is this going to help sleep first? Is this going to improve the appetite? How am I going to know that the anxiety is getting better when I have this person taking this? So stuff like that. So having these, setting up some expectations, and this is where the caregivers and even patients can be really useful, is ask these questions. Ask the questions from your provider, and hopefully you're not getting a whole lot of I don't know. And you might, there are times I'll say, I'm not really sure how long, I'm not really sure exactly what it's going to look like, but this is what it should look like. But at the very least, feel empowered that way. And as a provider, we should really be prepared, and we should be setting up these expectations. Next is alternatives. I probably would have said this has gone first, but it didn't work out in the acronym as well. So, hey, it's here. We should be discussing what our alternative options are for treatments, right? It's really easy for me as a provider to get that tunnel vision with a medication because I see a problem, I see a solution. But we should also keep in mind that we should be considering all of these kind of the what ifs, okay? What if the medication we think will work, it just doesn't? What if our patient can't swallow pills, but there's no liquid or chewable or crushable version of this medication? What if they don't want to start with medication? What if they'd rather do therapy? What if this medication is only partially effective when they take it? What if they don't want to wait 6 weeks to see this medication work? What if the medication makes things worse? Or my personal favorite, what if the insurance company won't pay for that medication? So if we're making sure that everybody's aware that we have, and that's the patient, the caregiver, other providers, that we have other options, and sort of talking about what those are, whether we want to start with them or whether we just want to consider them in the future. If you come to an appointment with me, you'll see the wheels spinning in my head. I start talking about, all right, so maybe we'll start with this one, and if that's not working, maybe we'll change to this other one, or maybe 6 months down the road, maybe we need to have this one in. Just kind of keeping those options open so that people have really, so that they have this confidence that even if the first thing we try doesn't work, and in this line of business, it doesn't always, right? That we still have options. We'll still try to find the correct answer to our problem. Okay. Next, most with the least rule. So our patients who have IDD, we should always be mindful of the high risk of polypharmacy, which means just a bunch of medications of different classes, or supertherapeutic dosing, which is basically dosing that's way too high. Maybe it's unnecessarily high, where we weren't seeing effects, we kept increasing it, kept increasing it to the point where we're having more side effects. And so if you follow this most with the least rule, or really try to get the most effect from the least amount and number of medications, you'll be more likely to avoid that polypharmacy and supertherapeutic dosing. What it does is it requires a lot of patience, both from the provider and the patient and the caregivers, and a lot of communication from everybody. So saying, but we really want saying that we are talking to each other and we're saying, we know it's going to take time to see this effect, but we're really going to try to pay attention to what is happening. All right. We just really want to make sure that we're giving these medications enough time to demonstrate any real effect. And then as we're titrating, or titration means increasing, we want to move slowly to just really avoid any of these negative effects. Just make sure that we're landing on that dosing that's enough to do what we want without completely overshooting our target and making things worse in some other direction. And really, if we can, we want to try to maximize secondary benefits. So if a medication, say something is particularly good for depression, but can also increase appetite for somebody who's having a hard time eating, hey, that's a great side effect, but maybe not. Maybe that wouldn't be the reason we would typically give that medication, but maybe that's just a little added benefit because they're already having depression. But so what we want to do is like think about managing focus with a stimulant, right? But you get too aggressive, and then all of a sudden this treatment's now it's causing anxiety and insomnia. Okay, if you do find that we've overshot that, don't add a medication to treat just the side effects. I think that's kind of messy management. If we can say, well, we know they have ADHD, but we also know that their anxiety is significantly worse and they're not sleeping on a stimulant, rather than just adding a benzo and or a sleep medication, why don't we just back off the stimulant, or maybe even look to a different stimulant, different formulation, maybe something that's longer acting or shorter acting, or just something, completely different non-stimulant medication, something to just improve the side effects rather than just trying to treat side effects with more meds that can cause more side effects, right? That's how we get polypharmacy in the first place. Last but certainly not least is just this idea of simplifying the medication regimen. And so it sounds a lot like the most with the least rule, but really what I mean here is just pay attention to that dosing strategies for medications, just make sure that it's going to work for the patient and the caregivers. Okay, so for instance, it can be really challenging to give a medication more than once a day. Anybody who's had to do that can kind of attest to that. So if we have longer acting formulations that are available, try using one, right? Try something that has extended release. And also just try to make your best attempt to order medications so that they're given at the same time when there's maybe there's no limitations for doing so. And what I mean is if we know somebody's transitioning every single day at a certain time, it may not be the best time to order medication, right? Like maybe there's a medication that can help with the transition, so that's why we do it, but we do it before then, but we wouldn't do it maybe at a time when we know they can't possibly get it. Really try to avoid prescribing sedating medications during the daytime, and then obviously stimulating medications at night. Again, nobody wants to be woken up by somebody who is wide awake because they took a really activating medication right before bed. And then really be willing and be sure that you are working between caregiver and provider to figure out what's the best time to give any medication, and try to keep things kind of, if everything can be given at once, usually that's best if we can do that. Maybe there's reasons we can't. There's a lot of reasons that we couldn't do that. Maybe this one has to be in the daytime, this one has to be at night. But if it's possible to kind of give them together, try to give them together. And then I always just kind of keep in mind like how often I forget to take my own vitamins, and then I realize that nobody wants to be taking medications. They don't want that to be like a chore, a difficult and challenging chore to take meds, especially when they're not even maybe the ones taking it. Maybe they just have to give it to somebody else. So it can be a real pain, and we should really try to keep that as simple as possible. All right, so keep that in mind before we're adding medications, and that's where the secondary effects might be really helpful. Rather than giving 2 medications for this, want to give one at one point a day. So try to keep things simple. All right. And then last, so that was kind of just as we're starting with medications, but let's talk about just follow-up visits a little bit. So once that patient is in that phase of coming to follow-up appointments, which may be days, weeks apart, maybe later on months, but it's time to consider just how medications may be helping or hurting the situation. So bring out those rating skills that we made up, the quality skills that we made up, that we got in the first visit, and just like figure out, okay, what's our impact been? Let's really monitor for any changes to like functional status, like talking about cognition, ability to participate in workshops, or any sedation or sleeping pattern or eating changes. And then because these patients are going to be more vulnerable to those sort of adverse effects. And so avoid making adjustments to the medications without having like a really clear reason. So quote, this isn't a therapeutic dose, that I might be thinking, it's not really a great reason to increase the medication if everything's working really well and our symptoms are under control. So just be sure to really communicate why we're making changes, and if you're the caregiver or patient, what you think is going on, why you might want to have a change. And I've definitely had situations where I thought something needed to change and maybe the patient didn't, or vice versa. And so just having that open dialogue is really important. Realize that we're all a team here when we're working on these things. Hey, I'm the doctor, cool, but that doesn't mean I know more about you than you do. And so it's really important that we just open up that dialogue. We feel comfortable being flexible with one another and just saying, hey, I'm going to listen to you, and I'll tell you why I think this could be good or bad, and you tell me why you would or wouldn't want to do it, and vice versa. Okay. And just be willing to work with everybody. All right. Patient, caregiver, treatment providers. And just really address any of those concerns, the side effects, any dosing strategies, behavioral or social interventions. And then be ready to highlight that. So as the provider, I'm only seeing you every once in a while, but I'm getting that really good snapshot in time. And so I might be seeing things that have changed between our last appointments, whereas maybe the changes were very gradual and not something that everyone else is seeing as well, because they're seeing the patient so much more frequently. Be willing to do that, but and highlight that, hey, this is really great. This is what I'm seeing. I feel like we're going in a good direction, but still being willing to listen to everybody else. And then as far as monitoring goes, we'll talk about different monitoring. Every medication is a little bit different. There's different monitoring requirements, so we'll go into them. But it's always a good idea to have baseline labs. So this is going to be kind of what I'll say is these are like the standard baseline labs that we should be getting for patients, the ID population, okay? So we should be getting these labs. And we want to do it at least annually, okay? So we want to get these at least annually. I learned from Dr. Julie Gentili that a really good thing was to try to get your annual labs drawn during dental examinations if they're already going under anesthesia. So don't just like knock people out to get labs, but if that's something that already needs to happen, that's a good time to get those labs, because it makes it much more easier if somebody has a really hard time getting their labs drawn. Some people don't have a problem with it, and some people do. So we just have to kind of keep that in mind, that labs can be really difficult. And so sticking to medications that don't require a lot can be a really good idea. But if it's something we need to do, we need to do it. But at minimum, I like to see these. I like to see a comprehensive metabolic panel, or a CMP, a complete blood count, a CBC with or without a differential, depending on if anything's abnormal, a TSH or thyroid stimulating hormone level, and then a beta HCG for women of childbearing age, so just pregnancy test. But those are at minimum. We should be doing those, okay? If we're going to give really any medications, just keep that in mind. As we get into, just a refresher real quick, what classes. So we have the antidepressants, which we'll talk about some of these individually, the antipsychotics, we have the first generations and the second generations, and then the tertiary generation, if you want to consider those. There's the mood stabilizer, anticonvulsants, ADHD meds, which includes the stimulants and the non-stimulants. And then we have the sedative, hypnotic, anxiolytics, and we'll talk about the benzos, hypnotics, anxiolytics, and sedatives, okay? All right, so here's the meat of this. We went through, I think, the most important stuff. We're gonna get into just some of the individual things, just to kind of give you a rundown on what we should expect with these individual classes. I really just like to think about them from the class perspective, because a lot of these just can really be grouped together, and so it makes a lot of sense. We'll probably have a lot more to talk about earlier on, and a little bit later a lot less, okay? So don't get afraid if you're looking at your watch and trying to figure out where am I going with this. But if you can remember these medications, these are the selective serotonin reuptake inhibitors as a subclass of antidepressants, right? These are the ones we typically are our go-tos for depression, anxiety, OCD, stuff like that. So talk about fluoxetine, sertraline, citalopram, escitalopram, paroxetine, fluvoxamine, don't worry, there's no test on those. You just remember these are the medication. These are like our go-to. This is our bread and butter in psychiatry in a lot of ways. These are actually generally pretty well tolerated. So for the most part, they don't cause a lot of sedation or anything in patients, with maybe the exception of paroxetine, sometimes sertraline. Every once in a while, I hear somebody say Lexapro, escitalopram. But they're generally prescribed usually once a day if we can, and for the most part, we try to give them in the morning because they're not going to cause sedation. But if they do cause sedation, go ahead and move it tonight, right? Like, makes sense. I try not to give a medication that I think might be activating for the first time at bedtime. But if you take it for the first time in the morning and you get tired from it, we'll take it at bedtime, right? Because again, nobody wants to miss a night of sleep because of a medication they took the first time. Let's avoid that. But for any medication I'm not really sure is going to have that effect, I say give it in the morning first and then just see what happens. Okay. Monitoring. So while these are really well tolerated, they don't have a lot of monitoring requirements. It's a good idea still to get those annual labs anyway. I'm going to say that for literally every medication. But at baseline, so we have that baseline because we're going to follow somebody for a long period of time. Hey, I just want to know what your labs typically look like. So if something does occur, hey, we have those. You go to the hospital or something, we can see what's going on. It's also kind of a good idea to get an EKG at baseline, and that's probably true for most medications. Just to know that we're having that. But a lot of these medications in the SSRI class can cause QT prolongation, which is just a change in the heart. So just a good idea to kind of get that. And really for some of these, it can cause weight gain. And so just monitoring the patient's weight, always something we want. But these are standard demographic things we should have anyway. Couple of pearls on these. So don't use SSRIs or SNRIs really with MAOIs, okay? Or thyroidazine or pimozide or tamoxifen. Okay, so just don't mix. That's very bad. We don't want to see that. One of the things though with these is that they can take about 2 weeks before you start to see any real effect. You usually will get the side effects in that first week or so, and those can abate. So you might want to stick it out for a week or so. But because these can have a lot of GI upset, giving it with food is usually a pretty good idea in this class. So you don't have that upset stomach. And for somebody who can't really communicate, I have an upset stomach, it's usually pretty nice. Hey, give it with food, see if we can kind of get past that. That again, will typically get better in a week, but it might take a little bit longer. If it doesn't go away, we got to do something else, right? Like nobody wants to have an upset stomach or be nauseous for the rest of their lives. So we just want to maybe adjust to something else. It can take about 2 weeks before you start to see an effect. Usually the peak is around 4, but it can be up to 6 weeks before you see that maximum benefit. So something you have to be really patient, just kind of wait it out. A lot of these do have liquid formulation, so that's nice. Citalopram has a black box warning for QT prolongation, and to be honest, I don't use it that much anymore because of that. I'd rather use escitalopram, which is now really inexpensive, generic, and works just as well, if not better. Paroxetine does have a short half-life, so you might want to be careful with that. You might see some withdrawal if you stop it really rapidly. So you want to try to taper off of it if possible. Sometimes we have this like really unpleasant withdrawal syndrome, and we're having a hard time coming off of it. A couple of doses of fluoxetine, which has a really long half-life, can sometimes really help with that. So that's something to just talk to your provider. But if you're seeing that there's withdrawal, usually it's best just keep taking it regularly until you can get tapered off of it. Okay, or call up your provider, or let the patients know that ahead of time. SNRIs, so the rest of these medications pretty much the same recommendations as the SNRIs. Just remember with these, just start low, go slow. Okay, that's really what we want to see with pretty much any medication, but these are really important. Start at lower dosing, lower than we might start with a lot of neurotypical patients. Start low, give it a good month, increase it, just watch these changes, okay? And so these are, think about duloxetine, venlafaxine, desvenlafaxine, milnacipran. Those are those medications. For the monitoring, same thing with the SSRIs, baseline labs, but really the EKG on this is much more important, as well as monitoring the weight, but because they have a lot more effect on norepinephrine, you're gonna potentially see a lot more cardiac side effects. So just make sure that you are using, I just read the question that was put up there. Make sure that you are getting the EKGs. One of the questions came in was, do antibiotics affect the effectiveness of psychotropics? I think we always think about like antibiotics affecting birth control pills, but there are going to be interactions, drug-drug interactions with a number of medications depending on the cytochrome P450 system within the liver and how it's metabolized. So without getting like crazily into the weeds with that, the best thing to do is that, and this is something we should do with every patient and every doctor that we have, is say, here are all the medications I'm taking, and because I don't have the ability to memorize the thousands of different medications that are out there. I mean, I know the 100 plus that exist in psychiatry, but my EMR is actually really good at kind of highlighting those things. But I think for the most part, because you're not going to be taking antibiotics long term generally, you wouldn't necessarily need to worry a whole lot about the effectiveness of the psychotropics, because the effects take so long to go into effect. It can take a long time for them to kind of revert back to. And so that's why if we're going to taper off any of these medications, I always say give it a good 4 weeks between doses. So you kind of give yourself between dosage adjustments, even if it's going down, so you can say, okay, this is where we're at now, but I'll talk about it a little bit later. And then with the SNRI, so getting back to that, I also do recommend getting that baseline blood pressure check. So making sure that you're just watching blood pressures, especially as we're increasing the medication. Couple of pearls. So again, these are the same thing as the SSRIs. It can take a couple of weeks before you really see any effect. You're going to see those side effects kind of early on, and then potentially maximum benefit about 4 to 6 weeks out. Venlafaxine and duloxetine can be really useful for managing neuropathic pain, along with depression and anxiety. So if you're seeing that this is something that's going on with somebody, that's usually a good idea to consider venlafaxine and duloxetine. Venlafaxine, though, is best when it's given as an extended release formulation or the XR formulation to really minimize withdrawal, because it does have a really nasty rapid withdrawal syndrome that can happen pretty quickly if you even miss a dose on the immediate release. But even if you're on the extended release and you stop taking it, you can still get that effect sometimes, and some people are more sensitive than others. And so it's always a good idea to taper off slowly, and the smallest XR dose is 37.5. And I just saw, I think they now have a 112.5 pill, but they have a 37.5, they have a 75, they have a 150, and a very, I think, expensive 225 that I've never gotten anybody. But those are and now the 112.5. But anytime you're stopping the antidepressant, so this kind of goes back to what I was saying before, anytime you're stopping the antidepressant, and it's because maybe I've reached my treatment goal, hey, I'm not having symptoms anymore, I feel pretty good, everything's gone, it's usually a better idea, rather than just stopping the medication cold turkey, just saying, let's reduce it by like part of a dose, let's reduce it by a quarter, let's reduce it by half, something, and then let's give it a month, let's see what happens, so that if symptoms start to return, rather than having to wait 4 more months to get the medication back up to that previous dosing, we know, hey, actually symptoms are coming back, I was actually doing well because the medication was working, not because everything's gone, let's just go back to it. That's usually the best way, just to give your brain the time to adjust. And then the atypicals, so I'm only going to talk about a couple in here because there's so many, but we talked about before bupropion, mirtazapine, and buspirone. Bupropion it functions a lot like a stimulant, which means it can lower the seizure threshold. And so the immediate release formulation should really be avoided in those with any eating disorders or seizure disorders, which can be really common in ID. And so it's usually a better idea to talk about giving the extended release. Really give this one in the morning if you can. Avoid taking it too late in the day because it can definitely affect sleep, especially the longer acting formulations. Although the immediate release, you're supposed to give it 3 times a day. So again, that's kind of a pain. So extended release, cheap for the most part, it works really well. That's one I would recommend. Dosing's pretty simple, 150, 300, 450. Don't go above that. With mirtazapine, it can be really, really sedating. And so really only want to give that one at bedtime. It tends to be a little bit, for some people, anecdotally, a little bit more sedating at lower doses. So higher doses can be a little less sedating, but more effective for depression and anxiety. But it can also cause a lot of appetite increase. So just keep that in mind. For the most part, it's actually pretty safe for the liver, the kidneys, the heart. So it's a good medication. It's a good augmenter, but you may have to watch it if appetite starts increasing. And then with buspirone, this one's really more for just anxiety than anything else. It's a better augmenter than anything on its own, but it does need to be given several times a day, usually 3 times a day. So it can be kind of difficult. Um, I have found that some patients like to take it as needed. That's not probably going to happen that much in the ID population, but it's really just best to be consistent with that one if you want to see it work. Does need a bit higher dosing for it to work well. Um, and then once it get so the monitor for bupropion, this one kind of gets back. All 3 of these, you're going to want the standard lab dose, a lab test, but you also want to do EKG and blood pressures with bupropion. And then you really want to watch out for any appetite loss or weight loss. So that might not be something you want for for a patient who's already underweight. With mirtazapine, the same as we already said, it can increase appetite. So just really watch the weight. Might be a good idea to talk about watching diet and exercise if you can. And then with buspirone, pretty well tolerated. It's just typical standard monitoring is usually pretty sufficient. Going into the sorry, pearls real quick. And so with bupropion, this one can actually be used with smoking cessation. So I don't see a lot of patients anymore that smoke, but it still happens. And so this one can be a really good one to help with smoking cessation. It also can be a really good augmenter for SSRIs if you're almost there but not quite. Also functions like a stimulant, so it actually be really good for ADHD as well, especially if there's co-occurring depression. It doesn't always worsen anxiety if in like generalized anxiety disorder, but it rarely improves it. But it can kind of uncover anxiety per se if you have a lot of comorbid depression. And so you really want to watch out for that. I really try not to use this with patients who have PTSD because it is really activating, and while it can really help focus at first, it really does seem to over time really start to spin them down. So just be really careful. The XL formulation that we try to use can't be crushed, and so it is something somebody has to be able to swallow. But the pills are actually quite small, so and not terribly difficult to swallow. Somebody can swallow them. With the mirtazapine, it does have it weirdly has a sort of faster onset, it seems like. And I think that has a lot to do with the fact that it improves sleep so much. The first time somebody takes it, they're going to sleep really well, which might just give you that effective thing saying, hey, I feel like this works really well. But it can also help with nightmares and PTSD to some extent. And so if you need something that's going to be you have PTSD, you have a lot of anxiety, depression with it, you might consider mirtazapine if you're not going to consider some of the other ones we'll talk about. But again, it will increase appetite, so you just have to watch out for that. They are crushable tablets though, so that's nice, but definitely don't use it in the daytime because they really do snow somebody out. Buspirone, they're all crushable, and so, but they do work best when using with another antidepressant. So I'll talk, there's a question in here about ADHD meds. So actually we'll get to that quickly if I can. So first generation antipsychotics, second generation, we remember these are the typical antipsychotics, becoming a lot less common in psychiatry because the newer ones are showing a lot more efficacy. They're at least comparably efficacious. They work just as well. They're really pretty safe compared to it. They're pretty tolerable for the most part, although they do cause a lot of weight gain. Potentially diabetes. So if it's deemed appropriate to like stay on a medication that's in the first generation antipsychotic class because it's working really well, just have these conversations. Just remember that if you're going to come off of it, there can be a lot of rebound dystonic reactions, which means like movement disorders because you're coming off of it, and there's withdrawals. So just taper off these medications if you're going to use them. But I generally recommend if nobody's been on them before, try not to start the first generations. When you're going to monitor these, you do have to do an AIMS. And so in AIMS is, if you haven't seen that and somebody's on this, they need to be doing AIMS. It's an abnormal involuntary movement scale. You got to do this at baseline. You really should be doing it pretty much anytime you're changing the medication or semi-annually. I do them at every visit for anybody on any antipsychotic for any reason, but pretty easy 5-point scale. Excuse me, looks at 14 areas of movement from 0, none to 4 severe. It just kind of helps us see, hey, are there any abnormal movements that are coming out from this medication, because the antipsychotics can all do that. But at minimal, we want the baseline labs. So we want CMP, CBC, TSH, beta HCG. We also want fasting labs and a hemoglobin A1C at least annually, but usually try to do it twice a year. And then for first generations, consider getting prolactin levels checked. and you have to be doing EKGs as well. For the pearls, consent. Just make sure that you're letting patients know that they can potentially get tardive dyskinesia, they can get neuroleptic malignant syndrome, and that can happen from any antipsychotic, so not just first gens, but really any of them. Make sure we're monitoring, we're doing our AIMS. We really shouldn't be using these medications specifically to sedate people as well, so just keep that in mind. We should be treating schizophrenia, bipolar disorder, severe agitation that might result in harm to others, or self. Okay, so those are the things we should really be looking at with these medications. We're going to second generations and the tertiaries. They're all pretty much the same as far as the recommendations. We're seeing a lot more of these medications are getting indications for patients with IDD, which is really good, but it still means we need to be responsible with our prescribing. Okay, so just because it says I can give this, great, that doesn't mean I need to give it or I should be giving it. So just kind of keep that in mind. I want to be treating psychosis. I want to be treating mania. I potentially want to be treating bipolar depressions, but I really want to ensure that I'm getting a really good, clear picture of what I'm doing, of what I'm actually treating when I'm treating. And so it gets back to that original stuff we talked about. Know what you're doing, know what you're planning to treat. If it's a really sedating one, risperidone, olanzapine, quetiapine, give it at bedtime. If it's more activating, maybe aripiprazole or brexpiprazole, give in the daytime. If it's maybe a little bit more neutral, just depends, like lorazepam. Some of these are a little bit more difficult than others. There we go. So in just addition to the monitoring recommendations for the first gens, you also really want to keep an eye out for diabetes mellitus. So hemoglobin A1C, really important to be watching for that. Hyperlipidemia, weight gain. So we want to make sure we're still getting those things, EKGs, all the standard labs. Consider if we're doing these to talk about nutrition consultations and do the AIMS, and sometimes talk about metformin might be not a terrible idea as well. Because diastonic reactions can occur with rapid titration, just make sure you're like increasing them really slowly, especially with aripiprazole. And the same thing can happen when you're decreasing them. So increase these pretty slowly. There's something called akathisia that happens with aripiprazole quite commonly, especially if you titrate it really rapidly. So keep an eye out for that. The feed forward cycle that happens with this is it looks like somebody's actually getting worse when they're on it, and they think, oh, they're having more psychosis or more mania, so they get more medication, which causes more akathisia. And it's basically this feeling of just discomfort in their legs. They feel like they have to move. It's really unpleasant, but it's hard for anybody to really verbalize what that feels like. And so beta blockers usually help with that, like propranolol, but it's a better idea to kind of taper off the medication and get on something different if that does happen. Risperidone can frequently be implicated with hyperprolactinemia. So what that means is with women, they can have inappropriate lactation, and then men potentially growth of breast. So just think about that as a possibility. Want to look for prolactin increases. And then clozapine is the strongest antipsychotic that we have available. But a lot of monitoring requirements, requires a lot of labs, can be really, really difficult. It doesn't mean we shouldn't use it. It just means that we really want to pay attention to the registry that we have to follow, and maybe consider starting with a second generation antipsychotic first, or a couple of them, making sure that we're not jumping to clozapine because we have weird side effects with the others, but rather because they weren't working to do what we're supposed to, then going to clozapine. Mood stabilizers. So we talked really about lithium, valproic acid, carbamazepine, and lamotrigine. They're all pretty different, but really just want to make sure the same thing with the antipsychotics. We're only really prescribing these when we need mood stabilization. So if just behavioral stuff, if it's just personality stuff, I really recommend staying away from these for ID population. Just remember, it could take quite a few days for lithium to hit steady state. So we might not see what we want to immediately. Doesn't mean it's not working. It just hasn't really gotten to the level yet. Watch out for sedation, weight gain, acne, cognitive slowing, tremor, increased urination. And then with all these, they are potentially teratogenic, which means that if somebody gets pregnant, they could have birth defects. So really want to watch out for all of these medications and just counsel accordingly. With valproic acid, same thing. There's some teratogenicity. Being cautious when you're using this and lamotrigine at the same time. Carbamazepine is can cause sedation. It's kind of an interesting one because it's an autoinducer, so it can actually speed up its own metabolism. And so the longer you're on it, the more you might actually need. So sometimes you do have to increase it rapidly if you need something. With lamotrigine, it does require very precise and slow titration. So there's a starter pack that it comes with, but there is a potentially deadly rash that can develop called SJS or TEN, Stevens-Johnson syndrome, or toxic necrotizing, sorry, I get it, encephalopathic necrotizing fasciitis, something like that. Anyway, medication should only be used for those who are able to maintain very strict adherence to the medication, which actually works pretty well for people with ID, but just be mindful that you don't want to use this at higher doses with valproic acid. For any of these medications, just pay attention to dizziness, somnolence, headache, nausea. For the monitoring, really what you should be doing is same kind of standard labs, CBC, CMP with div, or CMP, CBC with div, TSH, beta, HCG. With lithium, you should also watch out for diabetes insipidus, which can just be lots and lots of drinking of water, and that can actually be toxic if they drink too much water because they get hyponatremic. They actually have low salt levels. We should be getting trough levels for lithium. We should be getting levels for valproic acid and carbamazepine as well. But there's really no extra monitoring as far as labs go for lamotrigine outside of the standards. We don't really use lithium a whole lot anymore because it is so old, and we really should avoid it in patients who have renal dysfunction. Valproic acid should be used with those who have any liver dysfunction. Carbamazepine does have an extended release formulation that might be better tolerated, but you might consider that if lithium or valproic acid is ineffective for manic symptoms. And then lamotrigine might be a better option for patients who have bipolar depression versus mania. So you guys are asking some questions, and I'm hoping I'm answering some of them. I'll try to get back to them. As far as the stimulants go, so really the most important thing with stimulants that we want to think about is that we should really identify what we're treating with stimulants. So if I think someone has ADHD, let's really try to make sure that we're getting that diagnosis and we have a pretty clear diagnosis, and we're not seeing, it isn't just because these are normal things that happen with anxiety or depression or PTSD, but it's ADHD, okay? Because once we have ADHD, really should, we can use stimulants for most people outside of people who have like a really bad substance abuse history or where we think diversion's a big possibility, but it can be really life altering and positive if we're using them properly. We just want to make sure that we're using them and that we're writing on these symptoms. We're saying, this is what I'm trying to treat. Am I accomplishing that without causing other side effects? And if they have ADHD, it should get better. You can either start with methylphenidate or amphetamine salts. It really doesn't matter. If one isn't working, try the other one before you do something different. But try to just be slow and kind of work your way up. Avoid them in patients who have cardiac disease or even familial cardiac disease. Get your EKGs. We'll do that with monitoring anyway. But once you're stabilizing, try to look for things you can do daily dosing if possible. All the different like Vyvanse, Concerta, Strattera. So Strattera is atomoxetine. Those three are actually all different medications, as she asked, but they're three different classes. The lisdexamfetamine and methylphenidate, those are all, they're different classes, so they might have different efficacies or dosing or something, but for the most part, they can be effective, but somebody might respond better to one than the other. But try to look for things that we can use longer acting formulations. They're less hard, they tend to work a bit better. If we need to use like an afternoon dosing, stick to maybe smaller doses of immediate release if possible, but really just try to use single once a day dosing. Baseline annual EKGs are kind of a must. Blood pressure monitoring, common labs, kind of the things you would do with these medications. One thing about these medications is that they may not demonstrate efficacy the first time the first lower dosing. You want to kind of titrate up, but for the most part, they'll work and then they'll stop working, and then they'll work and they'll stop working, and so they either work or they don't. And so it's not usually a good idea to go the highest possible dosing, but start somewhere moderate and then kind of work your way up. And if it works, it works. If it doesn't, try something different. You might see anxiety, tremor, tachycardia, hypertension, and first cardiac symptoms, so just be careful with that. The non-stimulants, so a couple of these, guanfacine, these medications might take a bit longer to work. So with stimulants, if they do work, they should work immediately when they work, at least at the right dose. But Otherwise, they do tend not to have like a spin up with the rest of these. Guanfacine can be really helpful for concentration, hyperactivity, impulsive behaviors. But it might take 4 weeks for it to hit its full effect. So with Strattera, atomoxetine, great medication, works really well. Most people don't have the patience for it. It does take about 4 weeks for you to see the max benefit at a certain dose. And so when you're taking something every day and you're not seeing that effect, it's not, you get frustrated. But if you really can hold in there, it can actually be a really great medication once it starts to kick in. Same thing with bupropion, which we already talked about. And then there's modafinil. It can be off-label for ADHD. I don't really recommend doing that too much. With all of these, monitor UKG, standard labs. With guanfacine, because it's actually a blood pressure med, watch out for hypotension. With atomoxetine, pay really extra special attention to how the liver is functioning, and be careful with cardiac abnormalities. For some people, if somebody has hypertension and ADHD, actually guanfacine might be a better option because it can help with the hypertension. Atomoxetine is actually same thing. Just be really patient with that. Really patient with it. Just give it time. Give it lots of time. But it does work really well. I've been surprised at how well it works for a lot of folks. And if you're using modafinil for some reason, actually prazosin can block the mechanism of action. So avoid using that together. Getting to the benzodiazepines, the Z hypnotics. So benzodiazepines, it's best to kind of minimize the use of these in patients with intellectual disabilities, because there can be this paradoxical reaction which can cause disinhibition and disorientation. It could potentially worsen the behavior. So and it can disrupt the regular sleep cycle. So it's really best to avoid these. Now, if you're going to be using them, use them short term. And if you need to come off of them, do it very slowly. Z hypnotics, best not to be used longer than 14 days because you might get parasomnia. So just be really cautious. Again, try not to use these too often. Normal labs that we're looking for, but you might be looking at more cognitive slowing or memory alteration and chronic use. So or increased anxiety and decreased respiratory drive. So make sure that we're watching for those changes. Again, these are just really should be used as needed. I would say try not to use these too often. There shouldn't be giving multiple benzos multiple times a day. Like really should be looking at like, hey, here's one every once in a while, but there are other medications that might be better option. And it's over time, just not the best medications to be on in this population. With some of the anxiolytics, buspirone, we talked about it. Prazosin is good for PTSD-related nightmares. Sometimes it can be helpful during the daytime, but you have to watch out for blood pressure changes. So that's sometimes a good one. I try to give a daytime dose if I'm going over 3 to 5 milligrams at bedtime, but staying at a lower dose, like 1 milligram in the daytime. And then smaller dose in the daytime, maybe a larger dose at night. Just be careful of blood pressure changes or orthostatic hypotension. Propranolol is another blood pressure med. Usually it's best for people who are having panic. And so this can kind of block the sympathetic nervous system from giving you a fight or flight response. So just kind of watch out. Not usually good for generalized anxiety for the most part. This one we didn't talk about last time was a camprosate. Really cool medication, actually does have indication for patients with Fragile X. Can actually modulate GABA and glutamate. It's a really cool medication. It doesn't have a lot of side effects with other medications. It's relatively safe. You just want to kind of keep the dosing low at first, kind of work your way up. It does require TID dosing, 3 times a day dosing for some. Twice a day dosing does work pretty well for people. So just kind of work your way up and stay under that 2,000 milligram a day limit. And it usually works pretty well. Oh, the name of the anxiolytic I mentioned for PTSD is prazosin. These medications really don't require a lot of monitoring outside of maybe the EKGs and blood pressure for prazosin and propranolol. And then sometimes if you have prazosin, you can get this like drying of the mucus glands. So if you hear somebody really snoring loud, like really sawing wood, this may not be the medication for them, but you'll usually get that pretty quickly. But it's a good option. Propranolol really should be used for things where we're seeing, like we know it's going to cause some anxiety. That might be good, like before they do something that usually causes them to get worked up. You really shouldn't use it before like physical activity. So don't take someone, go to the gym. And then camprosate's really going to be off-label, and so you really just got to talk about what you're using it for. But when I find this to be a decent like 4th or 5th line option when we're really having a hard time with agitation in somebody who's just not able to control themselves very well, a camprosate sometimes works really well. And then with the last minute we have, just the sedatives. Really the big thing to take away with these is that the goal of a sedative should be to help people correct sleeping difficulties and get them back to a normal sleep cycle, not long-term use. So we really don't want to use it all like long-term, but maybe a couple of days just to kind of get them that confidence that they can sleep again. That's what we should be looking at. If we're looking at longer term use and we're still having problems sleeping or still really tired during the day, then it might be some sort of sleep apnea. So that should really go to a sleep specialist to get a sleep study done to make sure we're not making things worse, because if we're knocking somebody out who's not breathing, that can have a really bad outcome. And so monitoring is about the same as anything else. Baseline labs, just make sure, again, we're watching cardiac stuff because we're having sleep issues, potentially sleep. I'd say sleep studies are kind of a must if you're using these chronically. And then sometimes I like to use like something like melatonin or trazodone. I use melatonin first, maybe earlier in the evening, and then if they don't fall asleep, then try some trazodone, have that they're available. But most of the time, they don't end up using the trazodone because you're confident they'll fall asleep and the melatonin's working, and then eventually you can get them off of both. All right, so sorry to run through that so quickly, but we went through some of the general guiding principles and some of the recommended monitoring practices for using medications. There were some questions in here. I think I hopefully maybe kind of talked about the ones that Sandy N asked. And then I wouldn't, and so for Bethany, would I recommend lithium for somebody on a low salt diet? Generally speaking, I don't know. Salt and lithium are kind of interesting in how they're both, how they both function as molecules, but I would say if there's a big question, I probably wouldn't be prescribing lithium. I'd be looking for alternatives for pretty much anybody in that category, especially since they probably already like maintaining a lot of fluid, which means that it's going to be hard to get lithium to appropriate dose. And if you do get the fluid off of them, you're going to have toxicity with the lithium, so it can be really challenging. And then as far as prolactin levels of fasting, no, they don't need to be fasting for that. Sorry, Samantha already left. And then I think those were the questions. I apologize for ending so late. If there are any other questions, I'm actually going to hang around and I'll happily answer them for you guys. And that's it. But thank you so much, everybody. I hope the important stuff was covered kind of earlier, so we got the really, really important stuff out of the way first.
Just very briefly for everyone that's still with us, for CEUs, you're going to be receiving an email about an hour after the webinar's conclusion that's going to have a link to DODD My Learning as well as an enrollment key for you to get those. Nicole, there is a copy of the slides if you look in the GoToWebinar control panel under handouts. And Sierra, it will take us a few weeks, but we do plan on processing this and making it available on DODD My Learning as well. And like I said, I believe OMAS is going to be making it available on their LMS as well.
Awesome. Well, thank you to everyone who's sat through that, stuck it out, and especially those who caught both parts.